Thank you very much, Jacek. I'd like to discuss this topic. I think that with the time we see more and more interest around the osteotomy of the knee. So originally, osteotomies were designed to treat osteoarthritis, but with the time we see more indications related to treatment of the cartilage, meniscus, and ACL. So generally speaking, I think that any soft tissue reconstruction in the knee needs the solid ground for the regeneration. If there is a malalignment, there is evidence that the cartilage will not heal, the meniscus will not heal, and I'm gonna show you the evidence that your ACL will not heal or will fail if you unrecognize the problems with the alignment. So this is not only the problem of the alignment is not only related to coronal plane. I think I'm gonna bring your attention later in this presentation about on the sagittal view and to check for the tibial slope, because I think that this is a killer for most of the unrecognized problems for the ACLs. So regarding the varus alignment, the coronal plane malalignment, there is very good evidence showing that alignment can compromise not only the ACL graft, but also the normal ACL by the increased ligament tension. So this is something that you could probably see in some of your patients, that they do not have any injury, but they slowly progress to mild instability over the time after ACL reconstruction. Why this happens, even if you place your tunnels correctly, if there is a varus malalignment, as you can see, the more varus you apply to the knee, the more force you add to your ACL graft. And of course, this also explains so-called double or triple varus, as described by Professor Noyes, because when the ACL is torn, there's a tendency for the lateral opening, so you can produce not only varus malalignment, but also lateral and posterolateral instability. And osteotomy is a very good choice technique for treatment of the posterolateral instability in such cases. What about the other studies? This is a finite element analysis of the ACL. So as you can see on the right side panel, so the more varus you apply, so they tested 9 different combinations. So there was zero, so there was extension, 30 degrees of flexion and 60 degrees of flexion, and 3 varus situations, 0, 5, and 10. So as you can see on the right top panel, the 30 degrees of flexion and varus, 10 degrees varus produce quite significant stress on the ACL. The same in extension, 5 or 10 degrees varus causes significant load to ACL. In flexion, we don't see this phenomenon. The ACL is not loaded in such angles. Regarding the tibial slope, as you can see on the left side panel, the steeper your tibial slope, the more anteriorly tibia shifts. And I encourage every one of you, so on the right side, you see how can you calculate the tibial slope. And well, I usually, if I suspect the tibial slope problems, I usually use a long standing lateral X-ray, but you can probably do similar also in the short X-rays or on the MRI. This is a study showing the risk for the ACL rupture, and as you can see on the right top panel, all the dots are female patients, crosses are male patients. So you can see most of female patients, they have larger posterior slopes, and such slopes create quite high risk of suffering of ACL rupture, and this by by the way, explains the higher risk for the ACL rupture in female patients. This is the cadaveric studies showing the increase, how the force increase when the slope is increased. So let's say for 200 newtons, which is approximately 1/4 of our body weight, so it's not a big force. So when you change the slope from 9 degrees to 13, the tibia displays by 3 millimeters. If you increase the force to 1600 newtons, which is approximately 2 times body weight, the tibia is subluxed for about 8 millimeters anteriorly. And of course, when ACL is torn, this is even the force. Sorry, the displacement is increased up to 13 millimeters. What is the risk for the further ACL injuries in patients who have steep tibial slope? So this is the study from the Pinczewski group showing the 15 years follow-up of 200 patients who were treated by the same surgeon for the isolated ACL tear and with a primary reconstruction. And as you can see, the patients who had subsequent injury to either reconstructed ACL or the contralateral ACL, they have an increase of PTS up to almost 10 degrees as compared to normal patients who had not such injuries with a slope of 8.5 degrees. And the patients who had the ruptures of the ACL grafts or controller ACL, they had nearly 13 degrees of tibial slope. So the conclusion was that this group of patients, the patients who have more than 12 degrees, they had 5 times higher odds for recurrent ACL injury. So this is very important to also evaluate the patient and warn them for the second knee injury. This is also interesting study showing the catastrophic effect of age and posterior tibial slope on the ACL reconstruction. So this comes to Professor Domžalski presentation, again showing that the higher risk for a subsequent ACL injury or of the contralateral knee or the failure of ACL grafts are adolescent patients with posterior tibial slope. So as you can see, those patients who were kids, who were adolescents, they had posterior tibial slope increase. They had 11 times more likely to have an subsequent ACL injury of any of they both knees. So to conclude, we're gonna the high tibial osteotomy in combination with ACL reconstruction is the technique that can improve the alignment, and you can treat the instability just with the osteotomy, and of course you can protect your graft to improve the mechanical situation for the graft to heal, and of course osteotomies can control the advancements of osteoarthritis. The combined ACL reconstruction and HTO results in improvement in post-op functional scores, and there is a low risk of complications. In history, in past, this used to be split in 2 procedures, like described by Noyes. He generally indicated to separate osteotomy and ACL reconstruction. We see now there's more and more data in the literature that says that concomitant ACL.
I can't only call one person at a time.
Sorry. That ACL reconstruction and HTO are safe and reliable procedure. And actually, but at the end of this webinar, we're going to show you the video of ACL and HTO combined case. And coming to posterior tibial slope, do not overstress, do not do third or second ACL revision unless you checked for the posterior tibial slope, because you might be going into dead end road with such reconstructions. So as you can see, the patients who have increased posterior tibial slope, they have higher risk for ACL graft failure. And of course, there is a lot of techniques described in the literature of performing the anterior closing wedge osteotomy to control the steep posterior tibial slope. Thank you very much.